Welcome to Leadership and Culture in Healthcare. I'm Matthew Winn, podcast host, and we're into series two. Series two is about our national organisations, our leaders in national organisations and how they lead and how that makes an impact on healthcare. And we have Henrietta Hughes. Henrietta, why don't you introduce yourself, what you do, and let's start with how you got to do what you do in this national role.
Well, thank you so much for having me today, Matthew. And my role is the Patient Safety Commissioner for England, which is a fairly new role, which came about from the Cumberledge Review, First Do No Harm. But my journey to this role is a wiggly route. Many women's careers are quite wiggly. And I'm a GP. I still see patients on the weekend. And from that, I went to become a medical director. And that was because I was curious about what happened in the carpeted areas of the trust. And as a medical director, I found out what happened in the carpeted areas of the trust. And to be honest, it was a bit like being a restaurant inspector. You know, it was all the sort of worrisome areas. And I was initially in Camden and in North Central London. And then when NHS England was formed, I was the medical director and responsible officer for North Central and East London. And I did that for a few years. And then when the Francis Review was published and Freedom to Speak Up, I was very interested in the role of National Guardian. So I applied to do that. And I did that role for 5 years. And that's when we met, because your trust came up as the one with the highest score in the Freedom to Speak Up Index. And we set up a network of Freedom to Speak Up Guardians across England in trusts and in national bodies as well, and in HSBC and all sorts of other organisations. And after 5 years, I think I'd given it my all to that role. And when I went and did some other roles, including non-exec director and more clinical practice, the role of the Patient Safety Commissioner was advertised, and I applied to do that. So the role was a recommendation from Baroness Cumberledge. It's about listening to patients. It's about promoting patient safety, promoting patient voice, and doing that in the context of medicines and medical devices. My role is independent. I'm appointed by the Secretary of State for Health, and I'm accountable to Parliament. So I work with many different parts of the system, including parliamentarians, APPGs, ministers, officials, manufacturers, trade bodies, regulators, representative bodies, providers, ICSs, commissioners of all types, patient groups clearly, and their representatives as well. So it's a really huge sort of stakeholder landscape that we work with. And I'm supported by a small team of civil servants from the department who are seconded to my office.
So, Henrietta, I mean, it's fascinating. I mean, how you got there and all those various roles. I love the carpeted area of the organisation. I love that. It's yeah, whether it's good carpet or not, clearly is a debatable issue. We'll come on to how your commissioner role makes a difference. But when you think about your experience of leading organizations and being in leadership in organizations and creating a great culture, and you've said you've got a small team at the moment, your team at the National Guardian, I guess, was slightly bigger, and you've been in other big teams. How have you created a good culture to work in? What do you pay attention to?
I think there's something about spending time with the team. So one could sort of put it into the terms of visible leadership, communication and engagement. That all sounds a bit jargonistic, but it's actually being around, being available, and being interested in the people that you're working with. I'm very inspired by James Timpson and the Timpson test of really understanding about the people in your team. And I've always tried to create opportunities to get to know people and learn about what is their motivation, what is their life ambition, and how can I support them to achieve that? And so that might mean that for somebody it's doing a master's degree, for someone else it's spending time in clinical areas. It really varies from person to person. But also having a shared objective. So, you know, our passion is patients. Our passion is listening to patients, is responding to what people are telling us, and then helping to identify the parts of the health sector that need to do things slightly differently to make it better, partly individually, but mainly joining things up around the patient. And when that happens, it's a real kind of joy. It's a real area that we can get, you know, feel really warm about, that we've actually made a difference to people. And I would say that that's in my role as a GP. It's been certainly in the roles I've done as a medical director and as National Guardian as well, and thinking about the impact of all our actions on the outcomes for patients. But the one note of caution that I would say, and I certainly learned this from my work in as a National Guardian, is that leaders believe that it's really easy for people to speak up in their organisations, and workers think it's really hard to speak up in organisations. So as a leader, you're often the last person to know when there's a problem. And so, you know, that being available and spending time and creating that environment where people hopefully do have psychological safety is absolutely key. And it's not easy. It's really hard.
And whilst I know this is not your world any longer, but it's a world, as you say, you inhabited for 5 to 6 years, that key element of that, you just talked about the dissonance between people, what they think, and actually what the reality is for our staff. What do you think? Sorry, let me start again. Where have you seen great examples, and what are they do to actually bridge that gap, so the leadership knowledge of what's going on in the organization is the same as the experience of the staff? Well, if you tried to codify it, what would that be?
So if I was going to describe it in terms of the two ends of the spectrum, there was a trust that I visited where the chief exec had been in post for about 6 weeks. And everyone I spoke to in that organisation, I said, what would you do if you wanted to speak up? And I'm probably going to get Mark Cubbin's ears burning here, but it was Mark Cubbin's trust. And they said, oh, I just speak to Mark. I was like, Mark's only been here for a few weeks. I met him on the stairs. I met him in the coffee queue. I met him here. I met him there. And that sort of incredible ability to reach out and be available to staff, it sends a ripple through the organisation for people to say, I get this person, I trust them. And I know that if I needed to speak to them, I could. And it's a kind of secret sauce. At the other end of the spectrum, I won't mention the name of the trust. When I visited, the execs were actually in a corridor behind a locked door and never went out of that executive corridor. I think they were really nervous about what they might encounter. But I've also seen at the Walton Centre, they had a whiteboard where it was on the x-axis, it was all the different departments and wards, and on the y-axis, it was the names of all the execs. And the expectation was that every month, everyone would go everywhere. And I think if you've got one site and it's a fairly small, you know, organisation, that's more manageable. But it was the intention that I really liked about that. It was the intention and the expectation that that was what was normal. So I really think there's a lot we can learn from examples of you know, really practical aspects that people can take, and also some of the hazards of the virtual world and how we can use that to be again available and visible, particularly to people who are new starters, so that they get that feeling immediately that they can ask a question. They're not going to feel embarrassed or humiliated by asking a question to people who may or may not know the answers.
Yeah. And am I right in, Henrietta, that you set up the National Guardian from scratch? Is that correct? You were the first one?
I was actually the second one. The previous National Guardian had been in post for a few weeks and then stepped down because of conflicts of interest. So I thought I'd pretty much set it up from scratch until I did this job. And then I really know what it is to set something up from scratch, where somebody said, what was the first thing that came across your desk? And I said, I didn't have a desk.
And it's interesting, isn't it? The reason I ask, because I thought that was the case, but you know, you lost 2 national lead jobs have been setting up stuff virtually from scratch, and now from scratch, and that takes that means your print is over the culture of the organization from day one, isn't it?
Yes, and there's pros and cons to that. Sometimes it's hard to sort of separate out the role from the person, but I think the way I look at it is these are not flash in the pan. These are roles that should have longevity to them. And I think about the sort of architects of medieval bell towers who, they would never see the finished product. They would maybe lay the foundations, put the first course of bricks in or stone, and then have to hand over to the next person. And you want that next person to retain the vision so that you still end up with this bell tower that, as it was described in the original plan. But what you really need actually is a Medici who has that 100-year vision, who sets the whole thing up and allows the builders and the architects and the engineers to achieve that vision. And I think what I'm saying there with that metaphor is that what we need is that long range view where we say, look, we do have a goal, whether that's around patient safety and patient voice or staff voice or leadership or listening cultures. And what we really need is to somebody to actually hold the pen on that to see it through to where we want it to get to and not chop and change. So that longevity, that stability of vision, whoever's in charge, whoever's in leadership roles, we should be able to hand that baton on for the sake of our colleagues, our patients and the families.
And that's an interesting metaphor, because when I was reading about the Patient Safety Commissioner, just to refresh my memory, of course, because we all hopefully know what you do, but there, I came across some interesting words on there. The role of the commission: facilitate, convene, influence, advocate. They all point to what you just described as this being a long endeavor. This is not kind of, hopefully there are short-term gains and outcomes for certainly some of the things that you're involved with. And is that very much the vision and the approach that you're taking as the Patient Safety Commissioner, saying this needs to be here for the long term to make sustainable change?
Absolutely. And, there's something about having a very small team and an enormous sector to work with that forces one to work with and through other organizations. And I think that's really the only way to be effective in the health sector. And we are doing things all the time, which are wins. And sometimes I think it would be really nice to have a sort of wall of achievement to remind ourselves that things are happening. Because a patient contacted me with a photograph of a box of valproate dispensed in a plain white packaging with no labels, no information. And we know this is a highly potent teratogen and it should have warning labels all over it. And as a consequence, not only did I get in touch with the chief exec of the GPHC, who wrote out to 91,000 community pharmacists, but we actually also, pushed the minister to get the consultation completed, to get to the change in legislation that was required, that valproate would always be dispensed in original packaging. Now, that's a big thing, but it's also we're busy, so that would be Tuesday, and then Wednesday we're on to the next thing. And so it's sometimes you have to stop and celebrate, and I would say that to all staff working across the healthcare sector. We're busy and we're doing and we're achieving every day. What we're not so good at is actually pausing, taking a breath and going, that was brilliant, and then celebrating, because otherwise we're just so busy, we're on to the next thing, and it's only sometimes you have to be able to look back to see how far you've come. As I said, we started out without a blank sheet of paper. We didn't even have a piece of paper. We didn't have an office. We didn't have a desk. We didn't have a website. We didn't have any of these things. My 100-day report was very kindly published by the Patients Association because I didn't have a website at that point. So we really did start from nowhere and have built all of these relationships, and the ability to influence into, for example, the recommendations that we've made, or bringing Martha's Rule in, or working with the host of different professional regulators around consent, with lots of different parts of the system, and doing that convening, that advising and advocating on the patient's behalf to amplify their voice. So we now have a patient forum for the MedTech Strategy Programme Board, and it's developing for the Outcomes and Registries Programme. And we are continuously receiving a post bag from patients and representatives, and then being able to escalate that into, for example, MHRA, who have done reviews of isotretinoin, of fluoroquinolones and valproate. you know, and we work really closely with regulators, commissioners, etc., so that the right actions happen to make things better for patients and their families.
So the Commission, in a relatively short period of time, has become a patient kind of focus. It's become a route for people to directly feed into, to influence change on things that are causing harm. And did you expect that to happen so quickly?
Well, I think there's been a combination of factors. First of all, I had a lot of pre-existing, you know, good relationships across the healthcare system. And I think people from my previous role were used to me always having a shopping list of every meeting that I came to. And so in terms of organizations getting it, I think most people who work in healthcare really care about getting it right for their patients, you know, and whether that's their own patients or the patients of people that they're regulating or commissioning. And so it's a compelling vision that we can all get behind, not only to make things better for people who have been harmed, but more importantly, in a way, to stop that harm happening in the first place. And when we went out to consult broadly on our revised strategy, we looked to find alignment. And we're trying to create alignment with other parts of the system, whether that's with other safety organizations. I co-chair an informal network of the leaders of patient safety organizations, or in Patient Voice, where I'm part of a patient voice group with national bodies responsible for responding to patients. But also, I have a group of chief execs and other execs that I meet with regularly, an informal network where I can understand a bit more about what's getting in the way of delivering great care. So we're not just trying to make it better for patients and worse for staff. We want it to be better for everyone. And I actually don't see that that's a problem. I think that's a positive thing. I do sometimes hear people saying, you're listening to patients too much. I actually refute that. I don't think you can listen to patients too much. But it's really interesting that for some people, clearly, that's just not part of their business as usual.
Yeah. I won't comment on that at all, but yeah, I mean, how can you listen? I mean, we're all patients, we're all consumers of healthcare, and our experience, you know, sometimes good, sometimes not. But you mentioned as part of the role this 100-day report, so it's on your website. The link is up on, will be up on the podcast, and I was intrigued in there about one of your ambitions was to help make cultural change in how healthcare was provided. And so, Heather, just to have a think about that, how do you from a national organization really make a difference in the culture of organizations like mine? You know, you mentioned Mark Cubbon earlier, up in Manchester now, and he was down in, I think, Portsmouth when you saw him. How do you make a difference? What do you do as a commissioner to influence the changes in how people deliver healthcare?
Well, I'll think of a few examples. If I start with the Outcomes and Registries programme. So this was a recommendation from Cumberledge, and there were a number of registers that existed for medical devices, but mesh, and particularly patients who'd had pelvic mesh surgery, that wasn't included. So we had the joint registry, and we had some cardiac registries and other registries. And the ambition is to have a registry which is now up and running, which will eventually have around 2 million devices registered on it every year. And I think that's a huge cultural change, because what we're saying is, first of all, if you're going to have something put into your body and we find that there's a problem with that device, we should be able to do a recall as quickly as Tesco could recall horse meat. You know, it seems incredible that they could recall in 2 hours, and we didn't even know who's had mesh. Still don't know who's had mesh. We don't know who's had it. We don't know why they had it, and we don't know who's had complications. And that's really significant in terms of being able to provide information for people to consent to treatment. Until you know what the benefits are, the risks, the alternatives, and if you did nothing, then people can't make an informed decision or a shared decision about their treatment. And I think that's a big cultural shift. We're also looking at the principles around consent. And in the near future, we're going to be going out to public consultation on the principles of better patient safety. Because I believe that until we provide safe healthcare, then we're not actually meeting people's human rights, because access to healthcare is a human right. But if your healthcare harms you, then it's breaching your human rights. So I'm really keen that we get a really broad range of views included into our public consultation so that we can do something which is meaningful for patients and their families, but also for healthcare staff, for healthcare leaders, for the regulators and the whole healthcare sector. And we're really interested in the rights, the principles that already exist in the system and how we can bring those together into an overarching sort of proposition. But the other thing that I was going to say is that I think there's something about how we lead as leaders and how that impacts on the culture of the NHS. Because what I found from my previous role was that the speak up cultures in the national bodies was worse than those in the trust rated requires improvement or inadequate. And the culture that we have in the interaction between the nurse and the patient, or myself as a GP and the patient, is influenced by the cultures that layer up from the leadership and then from the people above the chief execs in trust. And this is why I'm really keen that the principles of better patient safety aren't just something which is good for trust. It would be something for the whole healthcare sector as a whole to take on board and own. Because we hear a lot about productivity, we hear a lot about finance, but unless we have safety as an equal player on that pitch, I think we have a problem. And I know from the work that I've done previously in NHS England and before, that when people are working in their perfect environment, then they have a 30% additional productivity. So if we see that productivity is going down, I don't believe that it's people are doing less or less interested. The systems are so clunky and difficult to work in that it actually impacts. So the more that we can do to facilitate, to support, to encourage, and to challenge where's needed, then we want to create that system that people work in, that where they're actually able to deliver great care to patients.
It's fascinating, isn't it? Because when you were talking about the devices registry, I was just kind of sitting there thinking, well, I'm going to be talking to chief exec of the NMC and the General Medical Council as part of this series. They're the type of people that then need to follow up from a regulatory angle on the back of what you're doing to then say, no, this is normal. You cannot, I guess we're going to end the place of saying there should be no devices going into a human being that isn't on the registry. Otherwise, you're not doing safe care. And that has whole sets of consequences if you go adverse to that. So I presume that's where that kind of goes, doesn't it?
Well, I think it's true. And certainly when it comes to consent, and I'm working with the professional regulators, including GMC, NMC and others, to align the way that we look at consent and how that information is shared with registrants and also with the public. Because at the moment, it's quite different. GMC is definitely leading the way there. And I would say that GMC, through the Responsible Officer Network, is also included in the Registries and Outcome Programme. So I see that we've all got a really important part to play to work effectively together in this, so that we're not creating an impossible situation for somebody where their employer is saying one thing and their regulator is saying another thing. And I was on the review group for good medical practice and made it really clear that there are certain things that, for example, you're not responsible as an individual registrant for the environment that you're working in. And we need to be able to separate that out and be clear. And we know that, for example, when it comes to just culture and the James Reason model, you have to be able to separate out what is an environmental factor, what is a substitution problem, and when is it actually reckless or negligent behaviour. And I would really rather that we get away from the situation where staff are fearful of being investigated for a problem which is actually out of their control entirely, and this sort of Swiss cheese model has happened and they happen to be the last person to touch the patient. This is all about the just and learning culture that we need to be able to have the right safety for patients and for those who are looking after them as well.
Yeah, and it's crucial, isn't it? For you talked about whole teams actually leading together and us, really showing a great leadership approach and behaviour. In one of the earlier podcasts, Graham Wareham from Surrey Borders Mental Health Trust gave a really good example of leadership was about stopping action against an individual when something goes wrong, because they've looked at all of the factors, the human factors and everything else. And in the end, it was quite clear that that person had no way that they could have done anything differently, because they were being affected by other people to do things that caused harm in a different direction. And it's understanding all of that and saying leadership is about A, stopping it happening in the first place, and B, identifying it when it goes wrong and not repeating it again. And that's tough to do, isn't it?
Absolutely. I mean, the other cultural intervention that I was going to mention is around Martha's Rule, because this is about listening to patients and families. This is about ensuring that we're checking in with people every day when they're an inpatient in acute and specialist trusts, before they have a problem, before they have a concern or they deteriorate. And what we know is that when that's done, it can actually reduce not only the deterioration, because people can flag issues 24 to 48 hours before their news scores deteriorate, but it also reduces the amount of complaints. And one of the things which I think is really important is that we free up time, including management time specifically, so that we have fewer complaints and we deal with those in a way which is timely, and we get the learning from that. Because I think it can be very it's distressing to families if they have a complaint and it doesn't get handled well and it's compounding the harm, but it's also takes time away and is very distressing for staff if they're involved in an investigation. So I think there are things, going back to your question, what can I do sitting in an office in SW1, and the answer is listen, respond, put policy in, make recommendations, and those recommendations actually then have traction. And the traction is the hardest bit, I think. A lot of recommendations get made. Everyone's drowning in recommendations. It's how do we get the right ones that actually are meaningful and make a difference, and evaluate them so that we can then see, the impact across the whole system, plus any unintended consequences.
And I think just one of reflection from you, Henrietta, on your national role, and you've done, as you say, a couple of national roles now. There's a lot of hidden work there, isn't there? That's a lot of influencing. I always describe it, given that I worked at NHS England, as arm wrestling across government to actually make sure the right thing happens and it gets seen through to fruition. And that I presume is quite a big part of your national role, to make sure those the ingredients are there to land Martha's Rule, mesh outcomes, etc.
Yeah, it's true. It's true. You have to be really relentless. But I think I honed these skills as a house officer. When you know what it is that your patients need. You've got this complex system called a trust to work out. I don't even think they were called trusts in those days, actually, a hospital, let's be honest. And how to navigate your way through this complicated system to get the things that need to be done, and find the people who have the the power or the influence to be able to do them. And one of the things I've learned is that if you ask people nicely, people are really happy to help. They're really happy to help. If you find it out who it is has that ability to make that change happen, people genuinely want to do the right thing for patients. And if they only have to do one thing, they'll very often do that one thing. And then if everybody does one thing, you then start to see the dial shifting. So, for example, with freedom to speak up, we put it into the constitution, the contract, the inspection, the leadership development, the chairs and chief execs framework, the national curriculum on it. It went into the quality accounts, board papers. It was everywhere. And that's because people only had to do one thing. It went into the Patterson recommendation. I mean, it just went everywhere, because we said, oh, we noticed you haven't included freedom to speak up. And people were like, that'll be the 11th recommendation on this report then. It always was the 11th recommendation. But I say that in a jest, but the fact is that you have to make something stick. And people are already saying that they're having different conversations about patient safety, that it's more of a priority, that it's included for the first time, for example, in the planning guidance. we're going to be putting it in everywhere because it's really important. And it's not to try and say it's more important than other things. It's just really important. And if you've listened to patients and families who've experienced harm, or to staff in situations where they felt that they weren't able to deliver safe care, then I think it really shows that it's something that we can all line up behind.
And you said it was in, so those listening to us from abroad, the NHS has a planning guidance, that's an annual process. And you said patient safety was in there, but it was light, wasn't it? I mean, I think you said earlier, the challenge is how do we make safety, patient safety, as an important pillar as our finances, as our activity, and say, and I would add our workforce data to say actually how well we're treating our workforce and our workforce actually supported in what they do. Presumably in your work, you want to really make sure there's a sea change in that approach across national organizations as well.
Well, you're absolutely right. I mean, I've always said that the artificial distinctions between people and culture and quality and safety, when I was a NED on a trust board, I was on all the different subcommittees in that area, because as far as I'm concerned, you can't really separate them. You can't separate, staffing from quality to safety to experience. What I also have to remember is, the guardrails around my role. And, my role is around medicines and medical devices safety and patient voice. So because every single part of the system could equally say, but my remit's this and my remit's that, one of the things that we're going to do is an atlas of powers to look at those powers and the remits of all the different safety organizations across the system to see where we have got overlaps, duplication, conflict, contradiction, and gaps. Because the way that I see it is that when we join forces, when we align and we get our safety organizations working brilliantly together, that's when we can start seeing the magic happening. And if I take you back to when I was a medical director, I had powers under the performance list regulations and under the responsible officer regulations. And those powers were powerful, but they weren't everything. So sometimes I needed to borrow powers from other organizations. So from the CQC, for example, who had unannounced inspections, we had to give 24 hours notice. Or from the police when it came to changing bail conditions for a doctor that we wanted to suspend. So if you can find out what other people's powers are and work with them and influence them, and then you find your shared ambition, your shared objective, and then you work together to make that happen, you don't have to have all the powers. My powers are to request information and make recommendations. So on their own, maybe not very powerful, but joined up with others, when we start finding out what everybody else's powers are, it might be the very powers that they need. So I'm quite excited about this, because I think the more we can lay the book open and actually all see what it joins up to, the more effective we can work as safety organisations and make more sense to providers.
You clearly need a new job title soon, Henrietta, because you've just described creating a new jigsaw that makes sense across the place, of which yours will be one element of it. And when you've done that, that clearly is well publishing. Just thinking a bit more about you then, as we go towards the end of this, you're quite remarkable in what you have done as a leader. When you just talk about, oh, I've just done this, I've been a GP and I've done this, and then I suddenly did this, and then you led 2 national organizations, still passionate about patient care. What's informed how you lead?
I mean, I know it sounds probably a bit trite. Spending time with patients is fantastic, because if you listen carefully to your patient, they tell you everything. They tell you everything you need to know. And I certainly have been informed enormously by listening to patients in my clinical practice and also in this role, and the experiences that people have had, but also listening to staff, finding out people's vulnerabilities. Everyone thinks, oh, well, they're a consultant, they're a chief exec, they're a this, they're a that, they should be fine. Actually, we're all humans and we all have vulnerabilities. And this is why I'm really keen that we look at the totality of the system and think about what's going well, as what we can learn from that, as well as where the gaps are. But I'm really, I would say, informed by my team. who are fantastic and are with me on this slightly crazy journey that we're on, because it's a charting. When you talk about a jigsaw puzzle, I agree with you. We found the corners and we found most of the edge, but we've absolutely no idea what's in the middle. And the more that we're able to fill in those holes, fill in those gaps, and actually build a system which is proactive, which is meaningful. But sometimes it can also, you get a bit of flack in these roles because we can't fix everybody's problems. And I know very much that, I would love to be able, every person who corresponds with us, to be able to say, no, I've got the exact perfect solution for this, but we can't. And that's actually quite difficult when you're dealing with people who've been to every organization and we're the new kid on the block, and they come to us and we say, we're not you.
Yeah, tough thing to do that, especially when that's what your role is for so many. And what helps you then, Henrietta, sustain that zeal, that passion? And you mentioned, you listen to patients and staff, but what do you do to kind of maintain your inquisitiveness as a national leader?
Well, I suppose I have my own experience as a patient. I've been a mystery shopper in many different parts of the health system, but also as a parent and a family member, and seen the kind of the good, the bad, and the ugly. I think there's also something about the recognition that I have a level of agency that others don't have. So if I'm struggling, if I don't feel that I'm listened to or I wasn't listened to, imagine how hard it is for people who don't have that agency. And so to be able to lend that to people who struggle, and to help to readjust the system so that people don't have to struggle in the first place. That to me is the absolute, creme de la creme of the whole job. To know that we've made changes happen that have, kept people safe in the future. But also, the work that we've done looking at redress options has been incredible in terms of seeing the impact, the true impact on patients and families who've been harmed. And the thing that I would say is that the more we're able to move away from that sort of oppositional approach to a more restorative approach, the better it will be. It will save a huge amount of time and anguish and money that we can then plow back into the positive, for that. So for the privilege I have of working in a role that I'm able to shape and influence the system from a health sector that is there to keep the nation's health better, that in itself is the absolute kind of motivator. And I think the word zeal is absolutely right.
Yes, I think it probably sounds it. And then finally, I guess, what would Henrietta be doing if she's not working? Or are you going to be telling me, no, I'm working all the time? I mean, how do you stop this from just becoming everything in your life? Because you've just said, you want to support as many people, and some people you're having to say no to, and you may be the last people they've come to. How do you balance all that as a national leader and say, I can still go out and not worry about X, Y, and Z?
Well, the first thing I would say is that we don't have an evening and weekend email culture. And I've worked in organizations that do, and it can become quite addictive, but it's very detrimental to family life. So unless you are working in a true emergency, part of the system, which we're not, I would definitely encourage people not to respond to emails in the evenings or in the middle of the night. You can put a delay function on your email so that it arrives at a sensible time of the morning. And I think the other thing about it is that remembering that work is, one piece of the pie, and there are plenty of others, and finding time for fun and family and friends and getting out and going on holidays and doing all of that. That's really important, because nobody's indispensable. And I strongly encourage my team not to take their work computers or phones away on holiday with them, and to come off the group, chat, the WhatsApp, when they go on holiday. One of the things I will say has been a real like a wheel clamp on my ability to work continuously is the fact that because I work in the, you know, with Department of Health assets, I can't take them out of the country. So even if I wanted to, the security protocols prevent me from doing that. So I can genuinely switch off on holiday and not try and, you know, keep in touch with the team, which I'm sure is a great relief for them. They get an awful lot more done when I'm not around.
And they clearly might need a break from you, Henrietta. You never know.
Exactly.
No. Well, Henrietta, it's been fascinating to hear you starting from GP, medical director, going through all those roles, the National Guardian, listening to, how you lead your team about that practicality. You've just kind of given that thing of don't email at the weekend, don't email in the evening, because that's not approach. And also, I think it's been really lovely to kind of hear that, which I guess is a plea as a new government comes in as well, that let's be in this for the long term. If we want to get patient safety right, it's not going to be fixed overnight. And there are probably the next 3, 4, 5 things that need fixing, which you no doubt have on your to-do list. And therefore, we need to be in this and get the culture right. So people know, yes, they can make mistakes, but they can correct those mistakes, and let's not make them systemic. And I'm just really struck by your passion for listening to patients, and I think we should all applaud you and not be swayed by people that say stop listening to patients. We should be saying listen to patients more. So it's been a fascinating listen to the life of someone who big difference to everyday patients, but kind of has to manage that at a national level. So Henrietta, thank you so much for spending time and sharing your insights.
Well, thank you so much for having me, and it was a great joy to spend time with you, Matthew. Thanks again.